Hi, everyone. This is Dr. Matthew Meroney at the University of Florida. Welcome to our live webcast titled Advancements in Minimally Invasive Spinal Procedures, Decompressions, Interspinous Spacers, and Endoscopic Methods. Thank you for joining us. Um, Let's see again. So I'm one of the assistant professors at University of Florida in the anesthesia department, and we are a sub-department, or in other words, the pain medicine department. I will be serving as a speaker and the moderator for this webinar. We are also joined by our other speakers, specifically Dr. Amir Jafari, who is the Associate Program Director for the Endoscopic Fellowship here at University of Florida. And there's potentially going to be another speaker as well, and we'll introduce them in the future. Let's see. So specifically, if you have any questions, please use the Q&A feature to ask questions or type them, in other words, for the panel to answer and discuss after the presentations. ASRA pain medicine staff will also give instructions in the chat box. Let's see. And all questions you submit are only seen by today's presenters and will be responded to in the order which they received and will be addressed at the end of the presentation. Panelists will answer as many questions as time permits and then kind of varying. You'll see at the bottom of your screen the Q&A icon, so use that to submit questions. All right, so I'll go ahead and get started with what I kind of call Endoscopic 101. Let me share my screen. And I have nothing to disclose. So I call this Endo 101, specifically rhizotomy. So rhizotomy obviously is a term equivalent to ablation, but beyond the percutaneous approach, there is an endoscopic approach. I really like this procedure because, for one, it can be very successful for pain relief. It can be done on almost anyone, and it's a great, I would say, low stress way to get exposure to endoscopic to increase your skills, your hand-eye coordination, and just to get into the world of endoscopic, which is nearly limitless. So there's multiple tools. So just kind of basically, if you look here to the left, there are multiple types of drills, which you don't generally have to use for rhizotomy, but we'll get into where you do. So there's a diamond encrusted drill. There's a carbide drill. The reason that matters is you can use that to target different things. And this probably will happen more and more in the future, but the carbide drill specifically can be used to treat areas that are being compressed specifically by metal. So if there is a pedicle screw that's jutting into a nerve root or a cage or something that maybe isn't placed perfectly or for some reason is causing an issue, you can literally use this drill to burr into a titanium cage. There's multiple different sizes, shapes. We most commonly use the 3.7 millimeter burr, but in tight scenarios, if we're using other equipment, sometimes we use different sizes. If you look here to the right, you can look at the main working cannula and the multiple ports. So there's obviously the largest hole or lumen is the working channel, which you can put multiple tools through. There is a camera that frequently is angled at different degrees. I would say most commonly 30 degrees. There's the irrigation channel, which we use continuous irrigation, and there's a light source, obviously. And this, you can see the generator that powers the drill. So the main tool you use is going to be the endoscope that has the working cannula in it and the camera. So this is the camera. I would say similar to orthopedic procedures. There's different types of working channels, specifically ones that are beveled or non-beveled, which can really impact your visibility. So obviously with the beveled, you have this kind of fingernail that you can use to scrape things. Benefits are you can really direct pressure in certain areas, but it allows tissue to kind of fall in your view. So in some cases, that's what we want. In some cases, You don't. So for rhizotomy, I'll frequently use the one that does not have the bevel just to eliminate anatomy that will fall into the view. But there's obviously many scenarios where you might do otherwise. So here's cup forceps, also called pituitaries frequently. One of the main tools we use is what's called the trigger flex. It's a cautery device. I think that's more of a brand name. For the main company we use is Eloquence, and so that's the name of their cautery device. But you can do a lot of work with this. You can ablate. I was using it yesterday to do an annulotomy and to ablate a herniation, doing an endoscopic decompression. It's very maneuverable, as you can see if you engage this handle. The tip will articulate generally away from the handle, and you can use this really like a finger, and you can access any point in your view. So it's a really, really nice tool, and it's pretty amazing what it can do. There's more aggressive ones. So there's the Quad Pro, which is just a double barrel trigger flex. Obviously, it can be more powerful. Benefits, negative of it's going to be a little bit more bulky. And then there's the arguably the most powerful, which is the bi-tip. Good thing about this is it can cut through anatomy really quickly, but it has limited mobility, so probably not best to use it when you're first starting out. So I'd like to kind of start with the case report to just point out why this matters. Why should you be interested in this procedure? So this is one of my patients, a 75-year-old male, had chronic axial pain, and he is status L5-S1 fusion. So as you do, his facet loading was positive. We did medial branch blocks, and he had successful medial branch blocks. And we did a traditional percutaneous ablation at the level above the fusion. And the right side was very successful, about 80%, and the left side was not successful. It was 10%, which, that could be just placebo as far as I'm concerned. But due to the fact I was suspicious that we had difficulty doing the percutaneous procedure. Because of his hardware, his pedicle screws. So he still had facet loading positive on that side. I repeated the MBB just to kind of triple check, and which did show relief. And then I proceeded with endoscopic rhizotomy above the level of the fusion, and he went from 10% relief, practically nothing, to near complete relief, 99% relief. So did better than the percutaneous side with hardware in the way. So this is not this patient specifically, but just a basic view. You can access or you can do skin access, one for each level. Once you get more comfortable, you could potentially do either one or two on each side and limit the amount of wounds. Because I'm working with fellows, a lot of times I'll do two or three, but you arguably could do it in just one. The incision's small, it's just big enough for the working cannula, so it's about a little bit over an inch and a half. It is, all these steps there's a lot of feel component to it, just like any other procedure. So when you'll use the scalpel to open up the incision, and I'll frequently penetrate a little bit deeper coaxial to my locate or to my target with a scalpel to access or penetrate the fascia, and then I'll use a dilator to pop through that. So the dilator, which let me get back to, I'm trying to get backwards. Stand by. So the dilator, which is this tool, is generally what you're going to use to penetrate and guide that to the anatomy of interest, and then you slide the working cannula over that. So obviously this is pointed, but it's not sharp. So there's a lot of tactile feel if you hit fascia. You can feel like you need to put a lot of force into it, and you can penetrate through a lot of things. But I like to put a little nick with a blade so that I don't feel like I have to plunge into it. This is also a useful tool in a sense that you can, at least for the rhizotomy, you can touch your target once you get at the junction of the transverse process and the pedicle where you would normally ablate, and you can actually use this to scrape a lot of the anatomy away and actually do a lot of the work. Where you will feel once you put some pressure on, it, you scrape that bone. It will initially feel, I would say, gooey, like there's a lot of anatomy over the bone, and if you scrape it hard enough, you'll feel it actually get kind of gritty, and you can tell that there's just bone left. And you can actually arguably do the ablate a big portion of the ablation just with that tool. I've never stopped at that point, but I would bet that it does a lot of work. So you can really, I would say, destroy tissue if that's what you're trying to do. Um, Let's see. So here's a fluoroscopic view of the working cannula at the level of the transverse process. And so this is what it looks like on AP. And you can see how in some cases, if the pedicle screw is over top the pedicle, it can be right in the way. I'm not sure if this is actually that patient. I want to say that the pedicle screw was kind of right over the target. So it looks like on lateral. So again, we're not going to the level of the neuroforamen. But this is one of the big reasons that this procedure has such an advantage, because you can get to the point where you use your or bring your tools to the level of the pedicle screw, and you can dodge anything you need to do. Like you could literally, I could see the Phillips head, access to the pedicle screw, and I could unscrew it if I, wanted to attempt to do that. Um, more specifically, a big question I always get is like, what's a patient that's really good for this? I think it's fair to say the more you get into these cool procedures, you'll get in this scenario very frequently where you'll have patients that fail everything, and they'll be like, all right, you have this new, miracle procedure, let's just do that. And I think obviously you want to avoid that thought process. Where I think it's useful, obviously you want to consider risk, um, but because generally you're going to use some anesthesia for this, at least MAC. I frequently do general. Um, but you want to, patient selection is the most important thing. I like choosing people that I would say are difficult candidates in general. So, there's the people that have adjacent segment problems. You're, suspicious that's their big issue. Facet arthropathy, percutaneous RF is difficult. Their facet loading is positive. They've had prior RFs. You could do it. A good way to test is do a traditional RF, and if they get some benefit, then that kind of obviously confirms that's part of the problem, and you could consider doing this because it's going to be a more thorough ablation. So a good example I would say is like, if you get, say you're going to get 70-80% for a percutaneous ablation, you could have 80, 90, 100% relief with this. Obviously it only treats facet arthropathy, but these are some of my happiest patients. From a patient expectation standpoint, there's generally some procedural pain afterwards, which was probably mild to moderate. Um, and so, generally most people actually feel better, I would say, directly afterwards. But, I might give something, I would say, simple like tramadol afterwards. But a lot of people don't even need that. But from a expectation, from a therapeutic standpoint, um, generally, it's triple to quadruple the amount of time that a percutaneous RF would work. So in other words, if you're thinking 6 to 9 months for percutaneous relief, this is probably gonna be like 1 to 3 years. I've definitely had some people that I've done. I think I'm past 3 years now, and I haven't had to redo it. But it's not magic, but it can work incredibly well. Um, So just from an anatomy standpoint, so if you look down here, you can see obviously the lamina, transverse process, pedicle. And so this strip right here is going to be kind of the target for me. You can see transverse process, and another example here. So if you once you start getting more intimate with this anatomy, you'll realize that transverse processes can really vary on size and shape. They're not like these flat platforms that you might kind of guess they are. So getting familiar with that it's a little learning curve, but it's not, I wouldn't say it's super scary. One thing I would say kind of important to be aware of, because you have so much ability to I would say cause destruction, which is kind of our goal. You want to be more aware of the anatomy that you could hit. So, we're trying to hit the medial branch, which is just at the junction of the transverse process and, vertebral body. Um, if you ablate right in that junction, you'll hit mostly just the medial branch, and you'll only, cause denervation to the multifidus. But once you start getting more lateral on the transverse process, you can hit the intermediate branch, you can hit the lateral branch, and that can denervate other muscles, which I'll get into. There are small blood vessels next to the transverse process, which you can hit. The good thing about it is it's really good practice for the more aggressive endoscopic, and that's one of another big reason that I would say it's so great is that you can kind of troubleshoot a lot of problems that would be really scary if you were near, in the epidural space. A little bit of bleeding off the transverse process what's the worst thing that's going to happen? It's not a contained space. It could cause some bruising. But it can obscure your view and make it kind of difficult. And if you do a bunch of these and get comfortable with it, then you kind of learn to troubleshoot all these things, and you can learn a lot of techniques to treat that problem. So just a lot of good reasons to do this procedure, I would say. Here's a view of one of our patients. That being said, I did a more aggressive, I would say, ablation on this patient. I likely probably did get the intermediate and lateral branch. We did it kind of, or actually, I think this is on a cadaver. I really wouldn't want to expose this whole thing. I'd want to just be at the junction of the transverse process. On the proximal end. So if this was a live patient, I'd be denervating some other, I would say some other muscles, though this is what one transverse process will look like. From a target standpoint, let's just say assume this is the cephalad aspect of it. You're going to want to ablate that junction a lot. I will do a strip all the way across to the caudate aspect of it. There's definitely some professionals, other surgeons that will just do it here for speed, just because the majority of your medial branch targeting will be at that junction. That being said, I feel like once you're at this point, it's really easy to just kind of do the rest of the strip lesion. I think there's an argument that it will last longer and have denser relief. So that's what I do. From an evidence standpoint, there's no randomized controlled trial or study that compares these to percutaneous, but I would argue it's pretty obviously superior. It's easy for me to say that, but when you have patients that fail traditional RF and this works great for various reasons, you understand the efficacy. So it's more of an expert opinion, but we're obviously just doing the same thing, just more aggressively, and from a logic standpoint, it's just gonna work better. So considerations from an anesthesia standpoint, I've done many under MAC. Obviously, from any surgical procedure, if they're under general, it's going to be more simple. There's less likely that they're going to get, have problems with the airway or anything like that. So I like to do it under general, but it's very easy to do under MAC. You just have to have a good, anesthesiologist that knows how to treat someone, sedate them while still maintaining, safety and making sure they don't become disinhibited. But realistically, once you get comfortable with this and you get your endoscope in the right place, you can ablate that nerve in a few minutes. So I would argue that I probably, if I had to race my fellows, where they're doing a traditional lumbar RF and I'm doing this, I could probably do it faster than they could do a traditional one, just because I could do it. I'm not sitting there changing views and testing and all these different things. It's just you kind of blade and get out. More specifically, the intermediate and lateral branches do innervate multiple muscles, and here's a picture of them. So they're significant muscles. So the iliocostalis, longissimus, spinalis, and then some of the skin laterals for the muscles. So you frequently can get a little bit of numbness at the skin, which is, not that that matters too much. So again, from a learning curve standpoint, this is a very safe procedure that helps you with a lot of the skills that you're required to have to do more aggressive, decompressions. Helps with the 3D orientation with the camera. Obviously, your hand-eye coordination. You're using both your hands. One hand's going to hold the working channel, the other and camera, and there's a lot of variables to consider and get comfortable with. You'll learn how to use device management, which I just mean by that is that you'll learn how to get comfortable with different tools the pump, the video, um, in some cases the drill, in some cases EMG. It's great for your staff to understand. I mean, it's better to train everybody in, I would say, a low risk environment than a high risk, because everybody can kind of understand just the flow of things. It is, I would say, complicated, but it's definitely so worth it. Um, and obviously, you can get familiar with all the tools. One of the big things that is useful is you can just deal with bleeding. And just to kind of, briefly go over that, there's things you can do for that. Is you can alter your pump pressure. So higher pump pressure is gonna compete for blood flow, in a sense that it will just not allow as much blood to leak out of either veins or arteries. You can practice putting direct pressure on it with different types of tools. There's different types of cautery settings to try to deal with that. In some cases, if you want to get used to the drill, you can actually get the drill out and deal with bleeding that way, or deal with, like if you have a Bertolotti's, you can go in there and you can just you can just drill it out, which we've done in the past too. It's really limitless, I would say. This endoscopic is just an approach at surgery, and I would argue that it is kind of the future. I would argue that though that we have a large elderly population that's about to retire. So there's going to be plenty of work to do, but I think the percentage is going to steadily increase in regards to endoscopic versus open procedures. So a question most people get is, a logical question is going to be, okay, you know, from a business standpoint, if you take someone that's, lumbar facet arthropathy is a problem, lumbar RFs are working, why would you do this? Because you're going to take a patient that you have a guaranteed procedure every, 6 months or so that pays reasonably well, and you're going to change it from every 6 months to every 1 to 3 years. And I think that's a fair argument. I mean, I would argue that patients that do well with lumbar RF and they're simple, I mean, yeah, I think it's probably fair to just do the traditional RF. But from an business standpoint, if a patient's going to compare your practice to 10 other ones, and everybody's doing the exact same thing, and you're doing endoscopic surgery, whether you're doing anything beyond this or not, that will pretty quickly highlight your ability, and show that I would say you're advanced and cutting edge, and patients like that. And obviously, if you talk to a patient and they want something that they don't want to do, a lot of patients don't want to do ablations every 6 months. And if you say something, you can do something that's going to work even longer, where they don't even need to be awake. I mean, a lot of patients are pretty excited about that. So from a marketing standpoint, I think that means a lot, because otherwise it's really easy to kind of just blend in with the crowd. Um, and probably more importantly, that this is a viable approach to do an RF to patients that are not good candidates in general, because I mean, most frequently they're gonna very, very commonly people will have pedicle screws in the way where you can't really visualize your target, and you're kind of estimating. And if you guys haven't figured that out now, it's pretty. It can get pretty complicated, and it's hard in a lot of those patients to be really successful. Um, Also, patients that have significant scoliosis, our neurosurgeons here are some specialists in scoliosis, so we see some pretty gnarly anatomy. Another example of where it comes into play is that you probably run into this, where if you're testing for a traditional RF and you have to pull the cannula back because they're endorsing some sort of radicular pain. In some cases, I would say uncommonly, but we run into that where you pull the cannula back so much that you're kind of questioning whether or not you're even treating that area, and that's just not an issue here. You don't even have to test. And if there's just something you don't like about the anatomy, they have transitional anatomy that nothing kind of makes sense. You can go in there and ablate, and it's in some ways just easier to be safe, because you can directly look at what you're doing, and you're not hoping you're putting together a 3D image or a 2D image on fluoro, and questioning if you're in a safe area. From an expectation standpoint, from a patient, if you do pretty much a medial branch block right afterwards, they're frequently pain-free. So in other words, you do the ablation, and then at the very end, while you're closing, you just drop a little bit of local, in the transverse process, and they wake up great. Generally, you just need a one suture at each location. So, if you're doing one at each, if you're doing L345, you're going to have six sutures. If you probably could eliminate that down to one or two locations. If you don't put local in directly before they wake up, they will be sore. So I think it's worth doing. Um, let's see. Um, I just like to call the patients in general. I feel like patients really appreciate that, and most commonly they're pretty happy. But similar to an RF, there's going to be, a few days, sometimes a few weeks where the procedural pain's decreasing, and then they can kind of really feel how good they're going to feel. So I always still tell people, wait a few weeks to really understand where you're going to be, because at each location they will be getting stabbed with a tool. They will have some procedural soreness. So I usually tell them to, don't judge it until a few weeks. Um, and kind of in a funny way, I've had patients that are older that they did so well afterwards. They felt so great that they went and did some things that they hadn't done in forever. I have a few stories from that I won't get into, but one specifically, like I had an older lady in her 70s. She felt so great that she went and rode a jet ski, for the first time in 30 years, and then she had a post-op herniation. So I always tell people to kind of, increase activity slowly, because you can get injured just from increasing activity. Um, Things we're thinking about. I'm already doing some thoracic endoscopic ablations here. We'll probably work our way up to cervical too. Just haven't really pursued it yet, but I think this is going to be more common from. I guess we'll get into the questions afterwards, but it's a great procedure. Let me get back to. So the next presenter is going to be Dr. Amir Jafari.
All right. My name is Amir Jafari. I'm one of the attending physicians at University of Florida. I mainly focus on endoscopic decompression, as well as other interventional pain procedures. But my main area of focus is, at the moment, this procedure. Today, I will be speaking about specifically decompression, both interlaminar and transforaminal approach. At our institution, we do offer this both cervical, thoracic, and lumbar region. All three are offered by my colleague, who was my mentor. However, I personally focus mostly on the lumbar region, and as well as Dr. Meroney as well. I Today I will try to present mostly case presentations, since we don't have a lot of time to go over details, just to give everyone an overview of what this procedure is about, what it can help with, and what the indications are. The spinal pathologies that we treat with this procedure are disc herniations, facet cyst, facet joint hypertrophy, ligamentum flavum hypertrophy. Bertolotti syndrome. Bertolotti's is when the transverse process of a L5 vertebral body decides to join and create a pseudo-articular surface with the sacroala, and this pseudo-articular surface could be quite painful. And the way we diagnose this is we basically find it in X-ray or CT and inject a local anesthetic steroid over that area. And if it resolves and lasts a long time, perfect. If it doesn't, then theoretically it can be drilled out, which has been done, and it's very effective. Other pathologies that are treated are central canal stenosis, lateral recess, and foraminal stenosis, all the areas that the spinal cord is involved. So during the initial visit, we want to make sure that we focus on great documentation, specifically regarding the physical exam. We do a thorough physical exam. We make sure to document the strength of the patient, each specific nerve, and also any numbness. Want to document any neurogenic claudication symptoms. Not only legally it's appropriate to document this, but also for insurance coverage as well. Any previous interventional pain procedures done at an outside institution is also, we try to make sure that we show if the patient has attempted conservative therapy or not. Any previous spinal surgery is very important, and that it's extremely important to not only ask the patient, but also evaluate the back. Sometimes people forget, and I look at the spine and there's a big scar on the back. So in a history of spine surgery means there's scar tissue. You get a small cut on your hand, you'd see a scar tissue. So imagine someone has a 3-level laminectomy. These scar tissues can be dangerous if you're not aware of them, and can lead to complications, as scar tissues can lead to dural tear and bleeding. Any history of bowel bladder incontinence, obviously if it's a chronic problem, it's not as urgent, but if it's changing and getting worse, it needs to be addressed immediately. So conservative treatment, not only it's appropriate to do it for patients, benefit, but also it's necessary for insurance approval as well. Physical therapy, we try to aim for 6 sessions or more in the past 6 months. If they've learned any physical therapy from their previous experience, they can definitely be doing this at home by themselves. Medication management, like gabapentin, Lyrica, Cymbalta is one of my favorite medications. Another name is duloxetine. Obviously, you got to make sure there's no counterindication to using this medication, like being on other, antidepressant medications. Diagnostic and therapeutic injections is another conservative therapy. Transforaminal, intralaminar steroid injections, radiofrequency ablations. These are all things that have been very successful in the past. There has been patients that I considered operating on, and I did a steroid injection, pain is gone. I haven't seen them in a year, right? These are very effective. So just because it didn't work on one person doesn't mean it's not going to work on another. It all depends on patient selection. Other minimally invasive pain procedures that are not as invasive as endoscopic decompression would be spinal cord stimulator, a minimally invasive lumbar decompression mild procedure, or Vertiflex, the spacer we put in. It's very important to also evaluate the hip and the SI joint. It could be missed. There has been a lot of instances where I get a referral from an external pain provider who does diagnostic SI joints injection and then sends the patient to me for a SI fusion. And I do a little bit more investigation, and I realize that the pathology is really coming from the spine, and this is a referred pain traveling over the SI joint. And just, I tell the patient, I could go inject steroids in your earlobe and your back pain can get better, because it's the systemic effect of steroids that get into the bloodstream and makes everything feel better. So just because there was a SI joint steroid injection administered and the patient felt better doesn't mean that is exactly where the pain is coming from. And in those scenarios, I personally do a diagnostic SI joint injection with local anesthetic only. And that, knocks out that systemic effect of steroids. Imaging that are used commonly, definitely an MRI is necessary, especially shows the disc and soft tissue. However, flexion extension is very important. This image is used to evaluate for signs of instability. I also use standing scoli X-rays to, if I'm really concerned for instability. Lumbar CT is another option. I really like looking at the 3D images of lumbar CT. This will help me figure out where the bony structures are, especially if I'm planning on doing a transforaminal decompression, because there are even a small amount of bone can make a big difference in compressing that exiting nerve. When someone has a disc herniation that sits there for 15 years, this disc will calcify. You're not going to be able to go grab this calcified bony disc and take it out. And there has been instances I have drilled discs because it's so hard. So these are all going to show up on a CT. Calcified ligamentum flavum, not going to be able to go cut it out easily. This is going to be using a drill for it. Again, it's going to jump out on a CT. Spondylolisthesis is what's you can see on a flexion extension X-ray, facet joint widening and effusion. You can see that on MRI. These are all warning signs that there's some sort of possible instability. And facet joint cyst, again, when a facet joint gets angry, facet joint is an articular surface between the superior articular process and inferior articular process. And when facet joints get angry, what happens? Someone, elderly person with severe arthritis, has knee pain, knee swells up, fluid builds in there. Same thing in the facet joint. Fluid builds in there, it can develop a cyst and push on the spinal cord. The cyst over time can adhere to the dura and cause problems, right? You go pull this off, you can cause a dural tear. So these are all, you have to evaluate all these things on these imaging to make sure you prepare for whatever is going to come show up on the surgery day. Spondylolisthesis, you can have anterolisthesis, which means where the vertebral body slips forward, or retrolisthesis, where the vertebral body will slip backward. And these are all signs of possible instability. The spine is a big unit of structure that has multiple surrounding supporting structure. Just like a building has a bunch of pillars, the spine has multiple structures that creates the spine that supports and protects the spinal cord. Now, when these supporting structures get weaker, interspinous ligament, the facet joints, the posterior longitudinal ligament, all these, when they get weaker, then you start noticing the slippage. When it slips forward, it's anterolisthesis. When it slips backward, it's retrolisthesis. So when I see these, I have to investigate further and see if there is truly instability that I have to worry about or is something minor. Degenerative changes in a facet joint and disc. Again, these could be leading to listhesis. Any pars defect, a pars interarticularis during traumas. Patients who do excessive hyperextension exercises, cheerleader, anything that there's hyperextension, power clean, power lifters, these could cause pars defect, fracture that pars, and it can lead to listhesis. Here's an example of anterolisthesis. As you can see that the top vertebral body is sliding forward on the bottom one. So, and here is the way we grade it. So when you see that first 25% is grade 1, second 25% is grade 2 slippage, and then on. Grade 3 and therefore grade 4. After grade 2, that's a warning sign. I know mess with it. I send them for neurosurgery to evaluate them for fusion. So let's talk about a case presentation. This is a real case that I have taken care of this patient. This is a female in her 60s, approximately 3 years of history of axial back pain with no radicular symptom, right? Makes it very difficult when you don't have radicular symptom because just like you have a fuse box at home, you pop a fuse, the kitchen goes out, you pop another fuse, the AC goes out. It's the same concept in the spine. Each dermatomal pattern in the leg will tell you which level of spine the pathology is coming from, especially people who have multiple abnormalities in their spine. It will help you figure out what level to focus on. This patient had only axial back pain, so she's failed conservative therapy, medication management. She was evaluated by neurosurgery, and the neurosurgeon sent her to me to evaluate her for endoscopic decompression versus an Intercept procedure, and also other diagnostic blocks and steroid injections. On the first visit evaluation, physical exam completely normal, straight legs negative, strength 5 out of 5 all around. No numbness, no tingling, just severe back pain going across the back. I did a diagnostic transforaminal steroid injection at L4-5, had 100% pain relief for a few hours. For diagnostic blocks, we use local anesthetic, small amount we wait a few minutes and then we follow that with steroids. So when the local anesthetic kicks in, it numbs that area and then it wears off and then steroids kicks in. Here's what the pathology was. This is a L4, L5 disc space. This is the sagittal view. This is axial view. As you can see here, this is what we're looking at. This is the left DRG. This is the right DRG. And you can see there's a paracentral disc herniation here. And in this view, you could see that the disc is coming up and touching the exiting nerve. So you would argue that, okay, well, if you really think that this disc is pushing on this exiting nerve, then you should have radiating pain down the leg. Well, this patient doesn't have that. So that tells you that that's not the problem. Not necessarily. This patient had complete resolution with the diagnostic block in this area. And also, the disc itself can cause axial back pain, discogenic pain. And this herniated area could be the reason. Here's another slice. As you can see, again, this is further out. This dashed line is telling me where my sagittal cut is in this axial view. And you also see that in the lateral recess, there's also narrowing. It's not really compressing the traversing nerve. This is the traversing L5 nerve. This is the exiting L4 nerve. But there is ligamentum flavum and facet joint hypertrophy here. That's even not, if not now, maybe in the future, she will have compression of this area. So my goal was, if I do anything, I like to future-proof this and free up this area as well. And here is the vertebral body end plate edema. This is why the neurosurgeon recommended either Intercept or decompression. They didn't know what's causing her pain. Axial back pain, all these abnormalities, what's the problem? It's very confusing, right? End plate edema, this is probably a modic type 1. It's lighting up on STIR and also T2. So I spoke to the patient. I said, look, you have these two problems. I think because you responded so well to the TFC, most likely endo will help you, but she wanted to take the least invasive approach. So we said, let's do the Intercept procedure. Intercept procedure is ablation of basovertebral nerve, which is a branch of the sinovertebral nerve. Basically, you put a probe in the center of the vertebral body, you ablate it, creates a light lesion, and ablates that nerve and helps with this vertebrogenic pain. It's a type of pain where it gets worse from going from seated to standing position and standing to seated position. Very hard to diagnose. You can't really do a diagnostic block for it. Here is a intercept procedure. This is only showing L4. Also did L5, but it's not in here. But you could see the probe right in the center, basically. And unfortunately, did not provide her any relief. Saw her at follow-up and said, okay, you know what? Let's proceed with the endo then, since we have exhausted the options. So I ordered a flexion extension X-ray, and with the flexion extension, you can see there's no listhesis at L4-5. So then I'm not concerned for any instability. I always order a flexion extension when I decide to decompress, manipulate anybody's spine, mild, vertiflex, anything, because I want to know if there's any instability in that spine and how bad is it. Then you can always compare before and after. So took her for endoscopic decompression, and this is the X-ray imaging of the procedure. We use fluoroscopy. Obviously, we have a scope and a scope tower we're also looking at, so it helps you. A combination of a live view on the camera and also fluoroscopy really gives you that good visualization. First, put a this is a stylet we put down, and it's placed at the junction of SAP. This is a guide wire we put down. It's placed at the junction of SAP and pedicle. The reason it's aiming down is because we don't want to hit the exiting nerve. So we aim down so we can bypass the exiting nerve. And we like to land right there at the anterior part of the SAP, at the junction of pedicle and the SAP. And that arch is actually called a Wagner arch. Then we place a dilator over the guide wire. Once the dilator is placed, we apply pressure and place it. By the way, all my endoscopic patients get neuromonitoring under general anesthesia. Neuromonitoring is monitoring all the nerves involved. It's placed in the muscles, and it is the same type of neuromonitoring ENT uses. So if I go ahead and start compressing a specific nerve or, sending electric signal to it, the neuromonitoring will inform me. So then we place this dilator, bullet dilator over the wire. We remove the wire, and then we place a working channel over the dilator, and we remove the dilator. So now I have a working channel over here at the SAP and pedicle junction. Again, goal is second disc space from the bottom. And I have a habit of naming discs based on the number of disc space from the bottom. There's people that have there's multiple people I've experienced have transitional levels. So you can easily make mistake numbering things. L4, L5, L5, S1, S1, S2. So I always say, okay, L4, L5, second disc space from the bottom, second true disc space from the bottom. This way there's no mistakes. You never want to do a wrong level, wrong site surgery. Once we have placed the working tube, then we use a trigger flex device, start working anteriorly and medially by burning tissue, burning disc. Our goal is to avoid damaging any muscular structure. And then we use the drill. As you see, this is the diamond tip drill. We go up to about 40,000 RPM with it. The diamond tip drill is drilling out a little bit of SAP, working medially. Starts at the pedicle, works cephalad, and drills out the SAP. The goal is to get medial close to this disc area. You can see that we were able to get our trigger flex medially. This is the AP view. This is the AP view. And we're reaching that medial pedicle border. And the spinal cord should be running around this area. As you can see that I was able to get the working tube completely to the disc area. Okay. And during this entire process, I am visualizing the exiting nerve. I found the DRG, it's sitting right there. I make sure I'm not compressing it. I'm looking at it, I look away. So we're aware of that exiting nerve. We know exactly where it is. We know the vessels around it. We don't mess with it. Now that I worked my way medial, remember when I said the lateral recess L5 traversing nerve is also my concern. I want to future-proof it. Well, the Kerrison is used to take out the SAP and the IAP from inside out. So I have found the epidural space, and now I am putting my Kerrison, which looks like an L, underneath the SAP and taking bone off, scraping bone off, trying to free up the lateral recess, pulling some ligamentum flammum from inside out. as you can see, my working tube is completely in there. I'm looking at the disc. I've freed up the foramen. I've freed up the exiting nerve. Now I'm focusing on the far lateral disc herniation. There was original problem. So I have basically shrunken it, and I have created an annulotomy, a small one, and I've taken out some herniated disc. I try not to create a big annulotomy, as this increases the risk of reherniation. Once I create the annulotomy and take disc out, what I do is try to seal that hole as much as possible. You can't completely do it by using the trigger flex device to burn that area and try to harden the disc so that reduces the risk of reherniation, theoretically. Here's what the nerve looked like after. As you can see, this is the exiting nerve. As I said, I was visualizing it. This is how it's coming out the foramen. You could see I have freed up around it. I have decompressed all the discs around it. And this is, again, another image of the nerve. And you can see underneath it, there's a shadow. This wasn't there before. So we have freed it up. We have shrunken it. We have used the trigger flex device, which is a bipolar cautery device. We've shrunken the disc, uses heat and electricity to shrink it. And this exiting nerve, this is the medial portion of it, and this is the lateral portion of it. And if you use the scope and look laterally, I did that. We decompress underneath it and continued. This patient did very well. I saw her post-op, 7 days, back pain completely resolved. The original back pain, she did have some soreness at the surgical site. Periosteal area is one of the most painful, most sensitive part of the body. So when you go and drill bone, they're gonna have soreness at the surgical site, but her original back pain was completely resolved. At the end of our cases, we also do an ESP block to help with post-op pain as well. So here's an example of our transforaminal epidural steroid injections. It is a diagnostic tool and a therapeutic tool for these patients. The way we do it is a little bit different than is traditionally done. Our goal is to get anterior to the spinal cord, not posterior. So the dura anterior of it. So our goal, we start lateral and we slowly advance medial, and we try to get really close to the vertebral body and try to get close to the PLL. The successful ones are when you inject contrast and we see the PLL light up a straight line, then we're happy with that because we know that that structure, that area is where combination of disc herniation and inflammatory soup, adhesion to the dura is all sitting there. So goal is to get anterior structure. This is when we inject the contrast after placing the needle. And as you can see that the contrast is flowing and catching the traversing nerve. This is the lateral recess, but this is anterior, right? If this was posterior, it would be useless to me. I want the anterior structure to get the steroids, not the posterior structure. And also you see the exiting nerve starting to catch some of it too. So here's another example, another pathology, totally different patient. This patient had symptoms of back pain, leg pain, and you could see that this is facet joint hypertrophy. What you see here is facet joint effusion, small amount of fluid. When you see fluid in the facet joint, you should start ringing bells in your head that, okay, is there instability or not? Because that means that joint is moving, it's angry, right? But not always. That's when I ordered a flexion extension to confirm that. But you could see here that the stenosis is so bad. It's not too bad, but it's causing nerve root edema. You see how these nerve roots are getting thicker? Here at UF, we call it Gator sign, but I'm sure there's some other people call it something else. But that means that these nerve roots, there's a tourniquet around them. So they're swollen up. You know, when we go to get an IV in the hand, we put a tourniquet, the veins pop out. It's the same concept here. So you could see that the lateral recess, the traversing nerve, barely see them. They're completely compressed. And there's central canal stenosis, barely see any CSF here. The good thing is there's some epidural fat. When I look at these patients, I want to make sure there's some epidural fat left. If there's no epidural fat, I get worried because I usually break the ligamentum flavum in this area, and then I start chomping it away towards dura. When there's fat, there's a gap between the ligament and dura. So when you poke a hole in the ligament, you know that there's some safety mechanism back there that you will have an empty space behind it, so you won't poke the dura. And here's another slice up. Again, you see the facet joint hypertrophy, bilateral lateral recess. There's degenerative disc disease, the disc bulge. So this spinal cord is being compressed from all sides, the back, the side, the front. This is the flexion extension of this patient. There's some retrolisthesis here, but not much. This could be because this is not a true lateral and it's not really a retrolisthesis. So I'm not really concerned about it. So I went and, this is one of the patients I decompressed at L3, L4, and all symptoms resolved. Back to work. The guy works a lot of walking for his job. So he was very happy with the results. This is another patient that was a puzzle. We get a lot of puzzles at UF. So this one had purely axial back pain, no radicular pain. You look at this, no neurosurgeon, the neurosurgery not going to offer this anything. There's no stenosis. But no matter what we did, nothing worked. Nothing. Medication management procedures, injections, steroid injections, nothing worked. So I look at this and I see this annular tear. Obviously, this guy's in a lot of pain. That's at his age. I think he was he's elderly patient. He kept coming back. So there's some going on there. So I see there's an annular tear here. This lighting up here, there's disc bulge annular tear. Some people with annular tear, it's very painful. So you can't, discount it. So what I did was I went ahead and did a decompression at this level. And this is an interlaminar. Now, interlaminar is when you go into the interlaminar window and you decompress. Transforaminal is when you go from the side. Interlaminar endoscopic decompression is another approach from back, posterior approach. So we find the tip of the descending lamina. Descending lamina gives rise to the IAP, inferior articular process. Ascending lamina is the bottom structure, gives rise to the SAP, superior articular process. IAP is posterior, SAP is anterior. Here's another example. Descending lamina, IAP. Ascending lamina, SAP. You see the IAP is posterior. So our landing zone is right here at the edge of the IAP. That way we can aim at the disc, we can aim cephalad, and we can drill caudate and take out the descending lamina. Here's a lateral view. We always save a lateral view before we start making incision with a spinal needle, showing that we're going to the right level. My target is last disc space from the bottom. Whatever the MRI calls it, L5, S1, S1, S2, last true disc space from the bottom. That's how we make sure we do the right level. A dilator is placed on the descending lamina. Here's a lateral view of the dilator touching the tip of the descending lamina. A working tube is placed. Half of the tip of the working tube is going to be sitting on the descending lamina. The other half is sitting over open space. It's just extending at the edge of Grand Canyon and looking at the canyon. Half of it sitting on the edge of the canyon. The other half is hovering over the canyon. And it's over the space. A trigger flex device is used to make a slit go over the tissue. Our goal is to avoid damaging any muscle. So we make a slit and try to create a flap and get under any muscles. We don't want to damage any muscles. That's the whole point of doing this endoscopic procedure, to prevent destruction of the supporting structure of the spine. So then the trigger flex is used to take out some tissue, to shrink tissue, then find the junction between the descending lamina and ligamentum flavum. Once you find that junction, then you start drilling. We start drilling up and down. We don't want to drill too lateral too much. Up and down to create a cavity for our working tube. A lot of neurosurgeons that do this, they don't even drill that much. But we get a very complicated patients who have medial fragments, a lot of loose fragments. So we drill a little bit to create a better opening so then we can maneuver our working tube better and catch all these fragments. Because these fragments, when they sit there over the years, they become inflammatory and they'll come back with more pain. Once we get there, this is a Kerrison device. Again, Dr. Meroney showed us what the Kerrison device looks like, but it will basically, the edge of it looks like an L shape. You hook it under the bone and another piece of metal comes down and basically squeezes the bone and cuts it out. As you can see, the tip of the trigger flex is basically touching the disc. I've gone in there, I've shrunken the disc down and burnt it. As you can see, there's not much destruction, right? This is the before on the left and this is the after. And all you see is a little cut cephalad. You don't see me shrinking the width of the facet joint much, right? We just drilled a little bit cephalad and a little bit caudate. Now here's a video of what it looks like. This is a straight punch. Remember when I said I will look for some epidural fat? This is when we use the straight punch to break through the ligament. We grab it, we cut away from the dura. Again, Straight punch is going in, grabs the ligament, hold, pull, and then cut. When we hold and pull, we wait for neuromonitoring. If there was a nerve being cut on the other side, you would hear it, the neuromonitoring going crazy. Again, this is what, once you break that ligament, you create the hole, you see epidural fat. What we do is when we're in this portion of the surgery, we increase our irrigation pressure. So once the hole is made, the fluid will fly in there and push the dura away. So that will create a gap between the dura, that's most likely sitting behind this fat, and this ligament. This space is very important because then we can put our structure, our instrument between this fat and this ligament and just start cutting away this ligament. Now here's a video of a curved punch now being used. The curved punch is going to go in there and it's going to go ahead and grab the ligament and start cutting away. I'm running out of time, so I'm going to move faster. Curve punch going in. Grabbing the ligament. And you see that dura right there, right underneath it. Boom, you cut it. And this is what the nerve looks like after it's been freed up. You can see that underneath it, there's a shadow. And the nerve is free. Another example. And this is when you want to look at what's the end goal. End goal is to see this pulsatile flow. The nerve is not adhered anymore, it's free, and there's a pulsatile flow. Another example of the nerve. This is an example of a disc. Disc coming out, being pulled out, a fragment of the disc. Some complications. Again, I'm running out of time, so I'm going to speak fast real quick. Dural tear is one complication. Obviously, we have treatments for it. If it's really small, you leave it alone. If it's, if it's concerning, we can use Duragen. And Duragen is basically just like a, bicycle tire. You get a hole, you put a patch on it, same concept. You go to seal, it's like a glue. You put it on Duragen and you slap it onto the hole. You want to make sure there's no nerve root sticking out. That can paralyze the patient or cause incarceration of the nerve root. Epidural hematoma, again, if you see, we always check for bleeding. If we see significant bleeding, we cannot stop. We use flow seal or gel foam. All right, that's my time. Thank you.
Thank you, Dr. Jafari. There's so much to talk about with that. I mean, we could talk about it for a few hours. So next up, sorry if I mispronounced your name, sir, Dr. Joseph Liao. I believe he works at Stanford, and he'll be presenting minimally invasive lumbar decompression and interspinous spacers, or at least maybe a shortened view presentation of that. It's all yours, sir.
Fantastic. And thank you very much, Dr. Meroney and Jafari. The endoscopic treatments are really groundbreaking and it's truly cutting edge. So fantastic work out there in Florida. So I'm one of the middle invasive spine and the neuromodulation specialists at Stanford. I'm Joseph Liao. I'm also going to be giving my colleagues talk on middle invasive lumbar decompression. So that'll be the second segment. So we'll try to power through this. So let's start the interspinous spacers. I don't have any disclosures. So what are we treating with interspinous spacers? Well, the most common things we're treating specifically are spinal stenosis and neurogenic claudication. As a consequence of interspinous spacer, we'll also be treating facetogenic low back pain, and we'll go over the anatomy of why that occurs. So everything that you need to understand about the MRI in regards to spinal stenosis is you really have to understand the gradation, both at the level of the central canal, the lateral recess, and the neural foramen. So I really recommend screenshotting this because this image will allow you and the radiologist to speak the same language. And that way, when you're trying to select patients for any sort of advanced intervention, you have a better idea of who's a good candidate or not. So neurogenic claudication, typically seen in geriatric patients. It typically presents as kind of a heaviness sensation in the lower extremity and the buttocks. Oftentimes you'll see them in a flex position. The classic presentation is a shopping cart sign, and that's because when you're in a flexion position, it ends up opening up that neuroforaminal space as well as the central canal space. And in regards to facetogenic back pain, as you progress in your fellowship and in your practice, it's really important to come up with a good way of diagnosing. Everyone has a different pathway that they use to come up with the differential diagnosis. In regards to facetogenic back pain, typically this is pain coming from the posterior element. So you can imagine things that causes lumbar extension or twisting motion will aggravate the facet joints here. Flexion will usually reduce the pressure unless it's extremes of flexion, in which case you're actually distracting the facet joints, and that can also be a pain generator. So with the interspinous spacer, on some level, you are able to reduce some of the pressure off of the facets. So how does it work? Here's a functional MRI image. This is with a patient that's completely maximally flexed and maximally extended. And as you can see, when someone is fully flexed, you actually do open up the canal space here. Whereas when you're extended, you can actually see the L45 and the L5S1 spinal stenosis here. So how does it work? Well, this image specifically is a picture of the Vertiflex device, but it's not unique to Vertiflex. All the other interspinous spacing device will basically prevent the body from having too much extension where you're triggering the stenotic symptoms. So ultimately, it decreases lumbar extension. It also distracts the foraminal opening and also decreases facet loading. So what is the data behind it? Well, this is with X-Stop, which was the initial treatment on the market. The reason why X-Stop isn't more popular is because it's not because it wasn't working. It's because the reimbursement for interspinous spacers just wasn't as high after you factor in the cost of the kits. But for practical purposes, there's no significant differences between each of the companies, whether it's Vertiflex or X-Stop, they all work quite well. In any case, this is a study, it's a randomized control study comparing X-Stop with conservative therapy for neurogenic claudication. It compares 42 X-Stop patients to 33 conservative therapy patients with a 2-year follow-up. What they found was that with the X-Stop patients, their neurogenic claudication symptoms were actually significantly better, as you can see here. So the ZCQ is a Zurich claudication questionnaire, and that's essentially a functional assessment of a functional assessment of the extent of neurogenic claudication one has. And what they found was that with the interspinous treatment through X-Stop, there was a 63% clinical success versus 13% in conservative care. Here's another study. It's a multi-center study. It's an FDA investigational device exemption study, which means they collect safety and effectiveness data. And also has a 2-year follow-up, and it's comparing 100 X-stops to 90 conservative therapy. And what they found was that the symptom severity improved in about half of the patient. Let me correct that. The symptom severity decreased by about 45% with the interspinous spacer versus conservative care where 7.4%. From a satisfaction standpoint, 73% of the patients were satisfied with the interspinous spacer and 36% were not responded well to just conservative care. And for those patients in this study, 6 patients in the interspinous spacer group went on to have decompressive surgery. The other 24, there are 24 patients from the conservative care arm that went on to get decompressive surgery. So it does show that the interspinous spacer does have some durability. Here's another FDA IDE trial with randomized controls setup comparing Vertiflex and X-Stop. So it's a pretty well-powered study, about 200 patients on each side with a 2-year follow-up. All of the patients had neurogenic claudication and moderate lumbar spinal stenosis for at least 6 months of conservative care. As you can see here, when you compare the amount of leg pain relief, it is almost identical between the Superion system and the X-Stop system. And in regards to low back pain, the findings were also identical all throughout the pathway, and even at the 2-year mark. And when you assess a disability index, they perform very similarly. So what does this show? It just shows that the device company really doesn't matter as much, just from a purely symptomatic and functional standpoint. Now, this is a multi-center retrospective European study. They follow about 1,100 patients for at least 3 years of follow-ups, and they use 8 different devices at 1 or 2 levels. What they really focus on was the complication rate. There was about an 8% complication rate. There were 27 cases of spinous process fractures and 23 cases of dural tears. And the failure rate, which involves device removal, was about 10%. 45 have no improvement or worsening low back pain. 42 had recurrence of symptoms after initially good outcomes. And there were 20 device dislocation. And this is out of 1,100 patients. Now, one criticism of this study is that it did not control for device variations, and also did not really talk about the level of invasiveness. So the conclusion for this study is that interspinous spacers are not substitutes for fusion surgery in major instability and spondylolisthesis. And the factors that increase the risk of complication were over-distraction, poor bone density, and poor patient selection. And we'll talk about why that is later. And another thing, if you are going to offer interspinous spacer, you want to make sure you're able to speak the same language with their spine surgical colleagues. You're going to read about something called Coflex. And Coflex is a bit different from traditional interspinous spacer because it actually also lifts up the lamina versus the traditional interspinous spacers, it only fixates at the level of the spinous process. And in the US, Coflex is the only interlaminar device. And as you can see, Coflex is typically performed by surgeons, traditional spine surgeons. And for them, they also see it as a bridge between decompression and full fusion with a full laminectomy. And this is just some data for the Coflex procedure. It's a prospective study, but there wasn't a formal randomization. They compared 31 patients who only got lumbar decompression versus 31 patients who got decompression plus the Coflex. And what they found was that both groups improved and there was no additional benefit with the Coflex cohort. Here's another study. It's another RCT with the FDA IDE involving 21 centers. They compared about 200 patients who had decompression plus Coflex versus 110 decompression with posterior spinal fusion. And the inclusion criteria was moderate to severe stenosis at 1 to 2 levels, and then up to grade 1 of spondylolisthesis. And what they ultimately found was that the population with the interlaminar spacer actually did comparatively to the group that had the posterior fusion. What they did also find was that the group in the posterior fusion tend to have higher rates of post-laminectomy syndrome, and part of that is suspected to be due to the hardware that's in place. So we're going to talk about how to perform this case. This is performed under monitored anesthetic care or general anesthesia. We routinely give ANSET because you are implanting and making an incision. And the most important part of this procedure is to make sure that you have a good position device to optimize lumbar flexion. Because the better that you're able to flex the lumbar spine, the easier it is to place the device because you will open up that space, just like how we would do it for a spinal cord stimulator. So here are the steps for how we perform it. You want to attain a true AP view with the spinous process midline at the desired level. In this case, it's 04. And then you're going to topicalize this area very generously with local anesthetics plus minus epinephrine to reduce bleeding. Then you want to mark out the inferior border of the superior spinous process and draw a line 1.5 centimeters down. And you really want to make this as straight of a line as possible. This will prevent us from having any deviation from the supraspinous and the interspinous ligament. And then from that point on, you make about a 1.5 to 2 centimeter incision midline down to the level of the spinous process. Next, you put in the dilator and you try to enter it the above the inferior spinous process with the initial dilator, and then you advance in a lateral view, and you just want to ensure that you stay midline the whole time. After that, you place a second dilator where you're trying to deploy the working channel. So you hammer that in, and then you want to make sure that you can actually see the aperture of the inner spinous space. And then after that, you remove the inner dilator and leave the working channel. After you put in the working channel, then you go ahead and place a reamer, which looks like a medieval torture device. But what it does is it actually helps clear out the soft tissue behind the ligamentum flavum. And after that, you remove the reamer and you open up and you keep the working channel in place. Thereafter, you use a sizing tool to look at the length of the inner spinous spacer that you want to place. If it's too large, you increase the odds of anterior column pain because you may cause too much lumbar flexion. And if you increase the lumbar flexion, two things happen. One, you're putting more pressure along the vertebrae and the disc. And number two, you may be distracting the facet joints too much. So you can have both posterior element pain and anterior element pain. And then if you choose a device that's way too small, it increases the odds of migration. So if you're in the case where a patient is somewhere in between two sizes, most people would err on the side of undersizing a little bit because there's a higher chance of complications related with oversizing it compared to undersizing it. After that, you want to uh, get a caudate tilt image down here and also a cephalad tilt up here. And this is just to make sure that the hub of the working channel is hugging the spinous process to ensure that you're still in that interspinous space. From that point on, you'll also place the actual device with the appropriately sized that you chose. And you're going to do this maneuver called sagittal arch, where you just move cephalad, caudate, and use this fulcrum to really ease the spacer deeper into the groove. Once they're there, you check the cephalad and the caudate view again, just to make sure that the wings of the spacer is still hugging the spinous process. And then once that occurs, you keep twisting and deploying until you hit resistance, and then you switch to a lateral view. At that point, you can fully deploy. And after you fully deploy, you continue to ream the device in until you're getting closer to the lamina. And the second most important thing with this procedure, other than the positioning, is to make sure you don't violate the spinal laminar line, which is the junction between the spinous process and the lamina. And the reason for that is because if you violate the spinal laminar line, that's when you run into trouble with possible epidural hematomas as well as a dural puncture. And then for closure, you close it like how you would for any midline incision for neuromodulation or any sort of spine interventions. How I personally like to do it is I like to close with a 2 vicryl simple interrupted, followed by 4 monocrol superficial running subcuticular stitch. And then I just seal it shut with Dermabond and I see them 10 to 14 days after. So what is the ideal patient selection? The ideal patient selection is someone with neurogenic claudication and or spinal stenosis, ideally moderate spinal stenosis. And you want them to have less than grade 2 spondylolisthesis because if they have instability of the spine, when you place that type of device, it has a high chance of migrating and you don't really fix the problem of the instability. And ideally, you want patients to have image evidence of thecal-sac or caudal-equina compression, nerve root impingement, and also if they have hypertrophic facets with canal encroachment. And in addition, depending on your local requirements to get the authorization, you also want to have a ZCQ questionnaire. Remember, that's a Zurich questionnaire to assess the extent of neurogenic claudication. You want to make sure that they have enough debilitation in order to facilitate this. And you also want the patient to have some sort of functionality at baseline. Because if they're not able to walk more than 50 feet or sit for at least 50 minutes without pain, then that tells us that this device may not be potent enough to fix their underlying issue. In some contraindications, if anyone's allergic to titanium or titanium alloy, that's a hard contraindication. In addition to that, if they have any sort of anatomic considerations like greater than grade 1 spondylolisthesis, or they have ankylosing segment at the intended level. Adjacent levels are fine, but not the intended level, or they have severe scoliosis, or they have a fracture at the same level, then you don't want to put in a spacer. Because if you put in a spacer, you have a high chance of causing further fractures anteriorly. In addition to that, if they have fulminant caudal equina syndrome where they have neurogenic or bladder or bowel dysfunction, you want to ensure that they get the maximum therapy, which is traditional surgery with a full lumbar decompression. Additionally, people with severe osteoporosis are more likely to have spinous process fracture. It happens with the even with the best placement. If that happens, usually there's nothing to do, but the patient may have some pain just from the bony fracture. If they have an infection in the area or anywhere, I will hold off on implanting them until they have some time to clear it up. Additionally, if they had a prior fusion or decompression at that same level, I would also not recommend advancing because sometimes with the scar tissue, when you advance towards the spinal laminar line, the scar tissue may tug against the dura and actually cause a dural puncture. And additionally, this is more of a soft contraindication. If their BMI is greater than 40, you want to give it some second thought. The thought process behind that's twofold. One is for concerns for wound infection, even though it's just a 2 centimeter incision. But the other component is if they're too heavy and if you oversize the vertiflex, the interspinous device, and they extend, there's increased weight along the spinous process, which would predispose them to fractures. And that is it for the interspinous talk here. And next, I'm going to give the talk on mid-invasive lumbar decompression. This was supposed to be given by my colleague, Dr. Samasi, but he had a family emergency. But we'll talk about this. This is percutaneous image-guided lumbar decompression, also known as minimally invasive lumbar decompression, which is mild. I also have no disclosures for this. So about 80% of the American population has back injuries at some point in their life. Low back pain is the second most common cause of disability in patients younger than 55. And about 15 million patients suffer from neurogenic claudication. And only about 5 million, which is about a third of them, seek treatment for neurogenic claudication. So this is just an image of different gradations of spinal stenosis contributing to neurogenic claudication. Now, the most important thing about considering someone for percutaneous decompression is that this method tends to work better only if people have ligamentum flavum hypertrophy, because a mechanism of performing this is
Dr.
to, yes.
I think you're not sharing your slides currently.
Oh, sorry about that.
No problem.
Thank you for that. There we go. Is that better?
Perfect.
All right, thank you very much. So if you look at the image here, you can actually see some ligamentum flavum hypertrophy. And the thought process is that it doesn't take a lot of decompression in order to open up the spinal canal and also allow some of the adjacent nerve roots to have more breathing room. So if someone has spinal stenosis and or neurogenic claudication, but they don't have enough ligamentum hypertrophy, they would not be a candidate for mild because if there's nothing to debulk, then you're really not making a significant impact on their actual anatomy. So this is an image of someone with ligamentum flavum hypertrophy over here, and you can actually see the spinal stenosis occurring at the 045 space. And in this image, this dark layer here, that's a ligamentum flavum. And you can see this is about a 6.75 millimeters thickness. The number you're going to look for is 2.5 millimeters. If it's less than 2.5 millimeters, statistically, decompressing that area is not going to help the patient get better. But if it's greater than 2.5 millimeters, then you have a higher chance of success. So here's some data behind it. This is a case series of 40 patients and 34 patients completed a 1-year follow-up. And as you can see, the pain relief is pretty remarkable. It's pretty comparable to standard epidural steroid injection, which is about 50%, even at the 1-year mark. And from a functional standpoint, you can see that there's about a 50% decrease in the extent of their disability. And they've actually measured that from the walking distance patients are able to do, and also the increased amount of time that they're able to stand. This is another study. It's an RCT comparing mild versus epidural steroid injection with a 1 year follow-up. And what they found was that consistently the mild patients had less disability, almost double the amount of decrease in disability at the 6 month mark. And at the 1 year mark, it's even more robust. And here are some other measurements that they assess. One is the actual pain score, as well as the claudication symptom severity and the claudication related function and the patient satisfaction. Consistently across the board, patients are more satisfied with the lumbar decompressive approach compared to just a traditional epidural steroid injection. So this is just another image to demonstrate how ligamentum flavum hypertrophy can impact central canal stenosis as well as foraminal stenosis, as well as stenosis around the lateral recess. And this is the most recent study called the Motion Study by Tim Deer in 2022. It's an RCT comparing conservative therapy with versus mild plus conservative therapy, and there was no crossover, and they followed for 1 year. And what you can see is that with conservative therapy alone, you don't see too much improvement in their disability function in the amount of disability decrease. But when you combine it with mild, you can see that their disability score decreases by about half. And this is also comparing subsequent lumbar spine intervention, meaning things that are more than a traditional epidural steroid injection. In the conservative therapy group, 26% of patients went on to get further interventions versus the mild group only had about 6% of patients who had more advanced spinal interventions thereafter. This is another study with 5 year data. And what they found was that the complication rates were low, and actually, in fact, intraoperative complications were zero. And if you look at the post-procedural complications, all of them were very short term, and they actually counted things as minor as ecchymosis and allergic dermatitis, which is only 2 of the 75 patients. And then for post-procedural pain, all of them actually subsided. There wasn't a single case of major complication. So this is a procedure. First, you get a true AP, and essentially you want to dock a working channel onto the lamina here, and you want to be just off midline. And the next view is the contralateral oblique, because with the contralateral oblique, that floral image is what allows you to measure the thickness of the ligamentum flavum. So the image you should be familiar with, which I'm sure you are if you're doing interlaminar epidural steroid injection, is the ventral interlaminar line. This is going to be your safety window. You want to ensure that you don't violate the ventral interlaminar line, because if you violate past it, then that's when you run into wet tap territory. Now, one caveat is that with the system, with the introducer, it is a blunt tip. So with the blunt tip, because we do a partial laminotomy, you actually want to just hover above the superior border of the lamina where you actually push the VIOL so that you can take chunks out of the superior border of the lamina. And many people will do epiduralogram pre and post procedure just to see if there's increased contrast flow. So after you put in your working channel, you go in with the bone rongeur, where you actually scrape off some of the bone here. And even more importantly, what you're doing is you're actually detaching the ligaments from the bony landmarks. And by doing that, you really loosen up those fibers and open up that space. Secondarily, you're going with a tissue sculpture. The tip of the tissue sculpture is actually sharp. So with this, you actually want to be careful because this is something that can actually puncture dura. And with the tissue sculpture, what you're doing is removing any residual soft tissue debris along that space. But the most important part is still going to be decompression with the bone rongeur. So in conclusion, percutaneous lumbar decompression is an effective way to treat neurogenic claudication caused by lumbar spinal stenosis, specifically due to ligamentum flavum hypertrophy. Patient identification is key, and you really have to make sure you read your MRI, measure the thickness, and know which levels to target. And other comorbidities are not prohibitive. This is one of the ways we're able to facilitate treatment with just mild sedation. And with that, that is the end of that presentation. And we have about 3 minutes for questions.
Is any other verbal questions? If not, I know it's kind of late, so we can let everybody go. Let's see. So on behalf of the ASRA Pain Medicine and the APPD, I would like to thank you for your participation in today's events. The next or ASRA Pain Medicine APPD Hot Topics webinar will take place in March 4th, and will focus on advances in neuromodulation, spinal to peripheral applications. We hope to see you then, and I hope everybody has a pleasant evening.
Fantastic. And we have one really quick question, which is the RVU assignment to facilities. At our facility, we get about 14 RVUs, but I've seen anything range from 10 to 17 RVUs. Hopefully that answers that question.
Thank you, sir.
All right. Take care, everyone. Cheers.
Have a good day, guys. Bye-bye now.